Dear students, we start second lecture, medical treatment for dyslipidemia. Plan of current lecture, we intend to discuss non-pharmacological management of dyslipidemia, pharmacotherapy of dyslipidemia, and we are going to discuss several main groups of hyperlipidemic medications, indications, mechanism of action, contraindications, side effects, etc. And also we intend to focus our attention at the statins as a very important hyperlipidemic medications, not only for decreasing of lipids, but also for decreasing the risk of cardiovascular complications. Non-pharmacological correction of dyslipidemia, of course, includes the hyperlipidemic diet. We recommend patients with dyslipidemia to restrict saturated animal lipids and avoid of using trans fats, increase also increase polyunsaturated fatty acids and vegetables and fruits and also cereals. But except that, we take into account weight normalization. Decreasing or excessive body weight can lead to decreasing of the serum triglycerides and increasing of serum high density lipoprotein cholesterol. Aerobic physical activity also is beneficial for decreasing triglycerides and increasing high density lipoprotein cholesterol. Smoking cessation is very important and should be recommended to all patients with cardiovascular diseases for secondary and also for primary prevention of cardiovascular outcomes. Smoking cessation can increase level of the serum HDL cholesterol. Education of patients is also highly important because educated patients, they usually have better compliance for pharmacotherapy. And high mountain hypoxic training is also recommended for management of dyslipidemia. It has been revealed by clinical studies that high mountain training at altitudes from 1,500 up to 3,000 meters above sea level is beneficial for serum lipids. It can lead to reduction of atherogenic lipid fractions in serum and high risk, but climate therapy, it is not routine method. It cannot be recommended routinely as it is recommended also only for patients with preclinical forms of atherosclerosis, mostly patients with high risk patients. We do not recommend climate therapy, climbing to high altitude region patients with severe cardiovascular complications with acute coronary syndrome, etc. How about pharmacotherapy? Let's discuss main hyperlipidemic medications. Here you can see a list of main hyperlipidemic medications: statins, bile acid sequestrants, nicotinic acid, fibrates, omega-3 polyunsaturated fatty acids, ezetimibe, and PCSK inhibitors. But do they have equal influence to lipids? Are they matched? Are these medications matched according clinical meaning in clinical practice? Here you can see that highlighted medication groups of hyperlipidemic medications. They have more important implication in clinical practice. First of all, these are statins, fenofibrates, ezetimibe, and PCSK9 inhibitors. Let's discuss a few of them. Bile acid sequestrants. These agents, they lower cholesterol and LDL cholesterol via bile duct sequestration. And here you can see that the place of influence of bile acid sequestrants in the intestines, they prevent they influence to bile acids and prevent absorption of bile acids. That's why finally they decrease LDL cholesterol. But these medications, bile acid sequestrants, they are not useful in all patients due to side effects. First of all, related with gastrointestinal tract symptoms. It can be constipation, and gas, increased amount of gas, and they cannot tolerate. They are usually tolerated not well. And bile acid sequestrants, they are not indicated for patients with high level of triglycerides and with history of hypertriglyceride-induced pancreatitis, and in patients with biliary bowel obstruction. Next group of medications, these are nicotinic acid and derivatives, and we speak about niacin. Mechanism of action, niacin influence to nicotinamide adenosine dinucleotide and nicotinamide adenosine dinucleotide phosphate, and niacin, it can decrease the serum LDL cholesterol and increase serum HDL cholesterol. By the way, niacin is available in clinical practice in two chemical forms. First, for treatment of nutritional treatment of pellagra as a nutritional supplementation, and second, in clinical practice, we use niacin as a remedy for hyperlipoproteinemia or peripheral vascular disease. The niacin is usually used in high doses from 1 up to 3 grams per day. And this drug is usually oral extended release tablets in different doses from 250 mg up to 1 gram or up to 3 grams per 1 day. By the way, niacin has several adverse side effects, and there are several clinical approaches in order to decrease the probability of onset of side effects. First, we usually start with very low dose, as low as possible. This approach can decrease the likelihood of adverse effects, and we usually try to slowly titrate daily dose of niacin for patients. Second approach, we do not recommend using of niacin with alcohol, because it can increase the risk of pruritus and flushing. By the way, niacin is contraindicated for patients with chronic alcohol abusers due to increasing risk of hepatotoxicity. And we usually recommend niacin after meal. Adverse effects of niacin include flushing. This symptom is usually accompanied with generalized pruritus, and patients, they complain of burning sensation. And this sensation is usually limited to the face and chest, and duration is approximately half an hour. But there is also additional clinical approach. We can recommend pre-treatment of with aspirin 30 minutes before taking of niacin. Or we can recommend laropiprant. This is a selective antagonist of prostaglandin, and it can also be used for prevention or treatment of these side effects, skin side effects. But we must take into account, we should take into account about patients with diabetes, because using of niacin can influence to glycemic control in patients with dyslipidemia. And moreover, results of clinical studies, you can see references in the bottom of this slide. Niacin has demonstrated increased fasting glycemic levels in patients with diabetes. That's why avoiding niacin therapy has been recommended in patients with metabolic syndrome or diabetes. Other side effects include hyperuricemia, GIT disorders, skin rash, or increased in homocysteine levels, hypertension, dyspepsia, in some patients increasing of liver enzymes, nausea, vomiting, and paresthesias. Serious adverse reactions include peptic ulcer disease, arrhythmias, anaphylaxis, hepatotoxicity, hepatic necrosis, fulminant macular edema. Next group of medications, this is group of omega-3 acids. There are several groups of medication, but only these above mentioned 4 omega-3 fatty acids, they have been approved by the Food Drug Administration, FDA, from USA. Indications, we recommend omega-3 fatty acids for adult patients who are older than, who are 18 years of age or older, with very high serum triglycerides, more than 5.6, 5.5 millimole per liter, as an adjust to diet to decrease triglyceride levels and decreasing of the cardiovascular events. And for administration and doses, you can see special recommendations for each omega-3, each type of omega-3 fatty acids. Mostly we recommend high doses, approximately from 2 up to 4 grams per day. Patients, they can take twice a day or they can use once a day. Mostly we recommend to take tablet or capsule of omega-3 fatty acids whole, without being crushed, chew it, or dissolved in the mouth. And by the way, it should be noticed that various dietary supplements in different chemical forms are currently available over the counter, but haven't been FDA approved. That's why it's very important that they are not required to show safety and efficacy prior to marketing the product. Omega-3 fatty acids, they generally they are safe. They usually have a few benign side effects. They are mostly related with GIT symptoms, eructation, dyspepsia, diarrhea, gas, nausea, fish taste, sometimes arthralgia, and each member of this group of medications, they have appropriate group of adverse possible side effects. But omega-3 fatty acids, they have several contraindications, cautions. First, we do not recommend omega-3 fatty acids for patients with who are using antiplatelet and anticoagulant medications, because omega-3 fatty acids, they can decrease platelet activity. Additionally, this group of medications, they are not considered allergenic, but patients who have allergy to seafood or hypersensitivity, they are usually not recommended using omega-3 fatty acids. And about monitoring, it is recommended to monitor LDL cholesterol and for patients taking this group of medications, especially who are taking desoxyhexaenic acid, and moreover, patients with dyslipidemia. Some medications, for instance, icosapent-ethyl, it can be used instead since it has no association with increased LDL cholesterol. About hepatic impairment, we recommend to monitor the liver enzymes. And about paroxysmal or persistent atrial fibrillation, patients with a history of persistent or paroxysmal AF, we shouldn't prescribe these medications because results of investigations published in 2015 revealed that this omega-3 fatty acid ethyl ester A, it has possible association with increased recurrence of symptomatic atrial fibrillation or atrial flutter. Next group of medications, these are fibrates. Fibrates, in contrast to statins, fibrates do not inhibit cholesterol biosynthesis. Moreover, these medications, they stimulate beta oxidation of fatty acids, mainly in peroxisomes and partly in mitochondria. Fibrates, they enhance lipoprotein lipase, resulting in increased very low density lipoprotein catabolism, fatty acid oxidation, and triglyceride eliminations. Finally, they decrease hepatic extraction of free fatty acids. Fibrates, they are useful in decreasing level of plasma fatty acids and triglycerides. Finally, patients who are taking fibrates, they have reduction of LDL cholesterol is about by 15% and significant valuable reduction of serum triglycerides of 35%. Fibrates, they are not indicated for patients with active liver disease, with renal disease, with primary biliary cirrhosis, gallbladder disease. As next group of medications, these are hydroxymethylglutaryl coenzyme reductase inhibitors. We use short title statins. These drugs, statins, they inhibit the rate-limiting step in cholesterol biosynthesis by competitively inhibiting the hydroxymethylglutaryl coenzyme reductase. Statins, they can significantly decrease the serum LDL cholesterol up to 25, up to 60%, and there are 7 types of statins: atorva, fluorova, lova, pitava, prava, rozova, and simvastatin. And we stratify above mentioned statins to 3 main groups by the ability of decreasing the LDL cholesterol. We stratify to 3 subgroups. Subgroup of this high potency includes atorva and rosuvastatin. They can decrease LDL cholesterol more than 50%. Moderate, second subgroup, moderate statins, they can decrease LDL by 30 up to 50%. And low activity medications, Simva, Lova, Prava, Fluva, and Pitavastatin, they can decrease LDL cholesterol by less than 30%. And we should notice adverse effects of statins. They can influence to some GIT symptoms, etc. But the real clinical practice, these medications, they are usually well tolerated, and most of patients, they can discontinue statin therapy due to fears of side effects. And we should remember about influence of negative lay media. But here at this lecture, I would like to highlight your attention at the most dangerous and important side effect, myopathy and rhabdomyolysis. And accordingly, the official definition from FDA, the myopathy, statin-induced myopathy, definition of statin-induced myopathy is this is an unexplained muscle pain or weakness which accompanied by laboratory changes, the creatine kinase concentration more than 10 times the upper limit of normal. And patients, they can complain to above mentioned symptoms, but we must check laboratory test creatinine kinase concentration. About statin-induced rhabdomyolysis, it is as a definition of rhabdomyolysis, it is a severe form of myopathy without a consistent definition, but patients with statin-induced rhabdomyolysis, they have creatinine kinase concentration increasing more than 40 times the upper limit of normal. And this side effect, rhabdomyolysis, is always always requires hospitalization. Because patients with rhabdomyolysis, they have necrosis of muscle fiber necrosis. That's why they have myoglobinuria, and it can cause development of acute renal failure. But we should remember about risk factors who for rhabdomyolysis who has higher likelihood of rhabdomyolysis. These are all the patients because they are more vulnerable. Patients with hypothyroidism, patients with pre-existing muscle disease, and other suspected risk factors include female sex, presence of type 2 diabetes, Chinese race, and possibly East Asian ancestry. But results of meta-analysis large randomized clinical trials, they have shown that risk of rhabdomyolysis is less than 1%, is about 0.01%. This data was published in 2010. It was meta-analysis of data from 170,000 of participants in 26 randomized trials. About myopathy and rhabdomyolysis, let's discuss. Let's compare different statins for risk of development of rhabdomyolysis. We take into account co-treatment with other drugs. First of all, we should avoid using of cyclosporine together with statin. It can decrease the probability of risk of rhabdomyolysis. And also we take into account the clearance pathway. And here I would like to highlight your attention at atorvastatin. Atorvastatin has mainly hepatic pathway, and it doesn't need dose adjustment in patients with mild to moderate chronic kidney disease. That's why in patients with end stage of renal disease, atorvastatin can be used, unlike other medications. As for simvastatin, it has mainly hepatic clearance pathway, but we use simvastatin with caution, and we use very low doses. We start at 5 mg. So that's why comparing with other statins in patients with chronic kidney disease, the atorvastatin is more preferable due to major clearance pathway, mainly hepatic pathway, unlike rosuvastatin, which has both hepatic and renal. And atorvastatin can be used in patients with end stage of renal disease. Other statins we have to decrease daily doses. But here I would like also to remind you the epidemiological statistical phenomena, number needed to treat. What does it mean, number needed to treat? This parameter can help us to estimate the probability, estimate the effectiveness of medication. And number needed to treat for aspirin is 248. What does mean 248? In order to get one complication of aspirin, we treat 248 patients. But how about relationship of statin with risk of myopathy and rhabdomyolysis? Here, the result of rhabdomyolysis, in order to get one case of rhabdomyolysis, we have to treat 1 million of patients with statins. That's why the real probability of myopathy and rhabdomyolysis in general population is very low. Contraindications for statins. We do not prescribe statins in patients with initial high levels of liver enzymes, more than 3 times from upper limit of normal. We do not prescribe statins in patients with hypersensitivity, so statins who has statin intolerance in history, pregnancy and planning of pregnancy, or lactation. These are contraindications. Statins are not recommended for children except patients with homozygous familial hypercholesterolemia who are older than 8 years, at least 8 years of age. Heart failure, fourth, third class by NIHA, who are not atherosclerotic genesis. For instance, rheumatic heart disease. Patients with aortic stenosis without coronary heart disease, patients on dialysis without coronary heart disease, and routine prescription for patients with autoimmune diseases in the absence of other indications for the assignment of statins is also contraindication for treatment with statins. Synthesis of cholesterol. In statins, we can see that statins, they interrupt cholesterol biosynthesis, they inhibit HMG CoA reductase. That's why statins interrupt synthesis of mevalonate, and then the chain of chemical reactions, and they decrease the synthesis of cholesterol. But along with the synthesis of cholesterol, statins also interrupt other chain of reactions of some important proteins, RAS and RHO, etc. That's why here I would like to highlight your attention at this process. Statins, they suppress HMG CoA reductase, and they inhibit granulation of two main proteins, RAC and RAS. These proteins are coupled to the transcription of pro-inflammatory molecules via MAP kinase pathway. So finally, statins, they reduce the expression of pro-inflammatory molecules That's why by suppressing the process of granulation of RAC and RAS, statins attenuate NADPH oxidase mediated production of reactive oxygen species. So that's why we can conclude that statins, along with the hypolipidemic activity, they have two additional properties. First, pro-inflammatory property, and second, is vasorelaxation. So statins, they can be considered as anti-inflammatory drug first, and second, vasodilators. Here, I would like to show you pleiotropic effects of statins. What does mean pleiotropic effect? Pleiotropic means additional effect, additional beneficial positive effect of medication, which is not related with main influence. For instance, statins are considered as hypolipidemic medication, but along with hypolipidemic activity, statins, they can cause additional multiple beneficial effects to the human body. First of all, they can decrease oxidative stress, they can increase apoptosis, decrease fibrosis, and they depress proliferation. Statins decrease endothelial dysfunction, decrease inflammation, and statins, they can suppress platelet activation and decrease coagulation. That's why all pleiotropic effects of statins, they are beneficial for atherosclerosis. That's why pleiotropic anti-atherogenic effects of statins, they can be subdivided in main subgroups. First subgroup, vascular influence to the vascular wall. Statins increase production of NO, decrease production of endothelin, decrease proliferation of vessels, smooth muscle cells. Next group of pleiotropic effects, they are related with influence on the atherosclerotic plaque. Statins diminish lipid content and increase stability of plaques. That's why these anti-atherosclerotic properties of statins are urgently necessary for patients with acute coronary syndrome with unstable vulnerable plaque. Next subgroup of pleiotropic effect, antioxidative properties, anti-inflammatory properties, because results of investigations, they have revealed significant decreasing of C-reactive protein, and especially high selective C-reactive protein in patients with under the treatment of statins, and moreover, the treatment of these statins was associated with significant decreasing of pro-inflammatory cytokines in blood, in serum in patients. And also, next subgroup of pleiotropic effects, influence of statins on coagulation and fibrinolysis is also useful for patients with cardiovascular disease. Next group of medications, this is ezetimibe. Ezetimibe, actually, this is synthetic medication, relatively new medication. The main effect of ezetimibe is related with the selective inhibition of intestinal cholesterol absorption process, and it was approved by FDA in 2002. Mechanism of action of ezetimibe, cholesterol is synthesis in the liver or absorbed from gastrointestinal tract, and ezetimibe is different from other lipid lowering agents because it doesn't increase bile acid excretion, or it doesn't inhibit cholesterol synthesis in the liver, it doesn't influence in the liver. to the liver, and ezetimibe inhibits the absorption of cholesterol at the brush border of the small intestine mediated by the sterol transporter Newman-Peak S1-like-1. And the decreasing in cholesterol absorption by the treatment of ezetimibe leads to diminishing in the delivery of cholesterol to the liver and increasing in cholesterol clearance from the blood and reducing hepatic cholesterol stores. And the decreasing in cholesterol absorption leads to decreasing in total cholesterol, serum total cholesterol, triglyceride, LDL cholesterol, and moreover, patients with treatment by ezetimibe, they have increased HDL, serum HDL cholesterol. By the way, ezetimibe that has no significant effect on fat-soluble vitamins, including vitamin A, D, and vitamin E, unlike bile acid sequestrants. That's why it's a beneficial property of ezetimibe. And finally, ezetimibe, by the way, ezetimibe is considered as moderate hyperlipidemic medication. It can cause decreasing of serum LDL as about 20%. Indications, ezetimibe is useful to reducing total cholesterol, LDL, upper B, and non-HDL in patients with primary hyperlipidemia, mixed hyperlipidemia, in patients with homozygote familial hypercholesterolemia as an additional medication, and with patients with homozygote cytosterolemia. Ezetimibe can be used as monotherapy in patients with mild, moderate hyperlipidemia, or in combination with other medications, first of all, statins and fenofibrate. How to use ezetimibe? Ezetimibe is recommended, it has a long half-life, it's about 22 hours, that's why it can be used once a day. With or without meals, with cholesterol-lowering diet. The dosage is 10 mg per day, so it might be taken at the same time as fenofibrate or statins, but if your patient is taking combination therapy, ezetimibe plus bile acid sequestrants, you should recommend to use ezetimibe at least 2 hours before or 4 hours after taking bile acid sequestrant. So, adverse effects. The most common adverse effect of ezetimibe include headache, runny nose, and sore throat. Less common reactions can be body aches, back pain, chest pain, diarrhea, joint pain, fatigue, and weakness. There have been reports of rhabdomyolysis, but in patients with combined therapy with statins. Contraindications. Ezetimibe is not indicated for patients with hypersensitivity to any components of the formulation. Concomitant using of ezetimibe with statins in patients with active hepatic disease is not indicated. Unexplained persistent increasing of serum transaminases also is contraindication. Of course, pregnant, breastfeeding female when used in combination with statins. When used as monotherapy, it is not necessary to adjust the dose in patients with renal impairment and patients with moderate to severe hepatic impairment. Monitoring, we recommend to control lipid spectrum at baseline and as clinically indicated after that. Liver function test at baseline if your patient is taking combination ezetimibe with statins, and in patients who are taking ezetimibe with cyclosporine, we recommend to monitor concentration of cyclosporine, and we recommend to decrease dose of ezetimibe twice 5 mg per day. Next group of medications, these are PCSK9 inhibitors. What does mean PCSK? Proprotein convertase subtilizing cysteine type 9 inhibit type 9. This factor, this is an enzyme, PCSK9. This is an enzyme. You can see this image, red colored figure. And this enzyme is found mainly in the liver. This cell, this is hepatocyte, but it is also found in the kidney, intestine, and central nervous system. This enzyme binds to LDL receptor, the blue colored receptor on the hepatocyte surface. This is surface of hepatocyte, resulting in degradation of the LDL receptor. And we rely on the LDL receptor to grab LDL cholesterol in the blood and pull it into cell for metabolism. So high level of PCSK9 leads to fewer functioning LDL receptor. That's why it leads to higher levels of LDL floating around. So therefore, PCSK9 inhibitors, they lead to higher numbers of functioning LDL receptors on the surface of hepatocytes, and they lead to increased uptake of LDL cholesterol into the hepatocytes, and then decrease circulating of LDL cholesterol. Impact of PCSK9 inhibitors on endpoints, results of investigations published in New England Journal of Medicine in 2017. They detected significant decreasing of long-term side effects, not side effects, endpoints, outcomes, cardiovascular outcomes, such as death, acute myocardial infarction, stroke, revascularization, hospitalization, under the treatment of PCSK9 inhibitors. That's why these medications are recommended for secondary prevention of primary and secondary prevention of cardiovascular complications. How to use PCSK9 inhibitors? We recommend to use once a month or twice a month. These medications are used in injections, subcutaneous injections, every 2 weeks or once a month. And these medications, PCSK9 inhibitors, they can decrease LDL cholesterol significantly. They can decrease triglycerides and increase HDL cholesterol. We have just described main hypolipidemic medications, but what is the main reason of using LDL, using lipids, serum lipids? Patients, they do not have complaints are related with serum lipids. Dyslipidemia, this is asymptomatic condition. The main objective of management of prescription of using of lipid lowering medications, this is influence to cardiovascular risk and finally decreasing the probability of cardiovascular outcomes. That's why before starting hypolipidemic medication, it has been recommended to assess the total cardiovascular risk, and it, according to the clinical guidelines, is published in 2019 by European Society of Cardiology. It is recommended to assess cardiovascular risk, and we assess cardiovascular risk using score system and using clinical data. First of all, we assess documented cardiovascular disease, presence or absence type 2 diabetes, and we assess cardiovascular main risk factors and presence or absence of chronic kidney disease, and assess the score system. According to score system, we can stratify patients to 4 subgroups: very high risk, moderate, or low risk. And we use results of assessment of score risk. But first of all, we have practical question how to manage patients with different cardiovascular risk according score system. And according this system, we ask ourselves what is the main reason for drug intervention. And patients with high cardiovascular risk who got score system 10, at least 10% and more of cardiovascular complications, we recommend to lifestyle intervention, and along with lifestyle intervention, we prescribe concomitant drug intervention. And it is very important to achieve and maintain target levels of LDL cholesterol. The treatment goal for management of patients with high cardiovascular risk is the achievement of appropriate target level of LDL cholesterol. And in patients with very high risk of cardiovascular complications, we recommend to decrease LDL cholesterol less than 1.4 millimole per liter, or at least 50% reduction of LDL cholesterol from baseline. That's why we have other question. What is the hypolipidemic power of medications? Do above mentioned groups of hypolipidemic drugs have equal influence to LDL cholesterol? Here we can see comparison of above mentioned hypolipidemic medications influence to several parameters, to all parameters of lipid spectrum. And we can see that decreasing of LDL cholesterol, the maximal decreasing can be achieved by using of PCSK9 inhibitors, second place statins, and then ezetimibe. If you intend to increase HDL cholesterol, the champion is nicotinic acid, and then statins. As for decreasing of serum triglycerides, the champion is also nicotinic acid. You can decrease triglycerides by up to 40% from initial using nicotinic acid and then statins, fibrates and statins. But we have at clinical practice, we have other question. How about tolerance? How about tolerance of medications? Tolerance of drugs are not equal. Bile acid sequestrants are very bad tolerated. They have multiple effects especially from gastrointestinal tract. Also for nicotinic acid is usually not well tolerated, especially when we speak about high doses of nicotinic acid. That's why we focus our attention at other medications who are well tolerated by patients, because bad tolerance or bad tolerance of medications means low compliance. As for PCSK9 inhibitors, current time we do not have oral forms of PCSK9 inhibitors. Patients have to use subcutaneous injections. That's why we focus our attention at statins. Statins, they are not, the current time statins, they are considered not only hypolipidemic medications. Statins, they are drugs for prevention of cardiovascular complications. That's why we use statins for secondary and primary prevention of cardiovascular complications. I would like to show you results of clinical guidelines from European Society of Cardiology, statins in patients with type 2 diabetes. They are indicated, they are recommended for patients with type 1 and type 2 diabetes. For patients with type 1 diabetes and microalbuminuria or chronic kidney disease, we prescribe statins independently from the initial serum LDL cholesterol. For patients with type 2 diabetes and concomitant cardiovascular disease, chronic kidney disease, or patients with type 2 diabetes and the presence of risk factors, for instance, arterial hypertension, smoking, obesity, or patients with type 2 diabetes who are older than 40 years old, we recommend using statins and try to achieve target level of LDL cholesterol less than 1.4 millimole per liter, or at least 50% from the initial LDL cholesterol. How about patients with chronic kidney disease, stage 3 and more? Stage 3 and more stage 3 of chronic kidney disease means GFR is at least less than 60 milliliter per minute. We ask one question: Is this patient under the dialysis? Is your patient under dialysis? If no, prescribe statins. If necessary, combination statins with ezetimibe. If your patient is receiving dialysis, ask other question. Has your patient has your patient used statin therapy before receiving dialysis? And second question, other indications for statin therapy? If no, refrain from statins. If yes, we prescribe statins. Next, clinical situation, patients with hypertriglyceridemia. Hypertriglyceridemias, we notice that levels of triglyceride and HDL cholesterol are not targets for therapy, but it is recommended to achieve target to decrease serum triglycerides less than 1.7 millimole per liter. But in clinical practice, you can see patients with extremely high serum triglycerides, at least, for instance, 10 millimole per liter and more. These are patients with severe hypertriglyceridemia. They have very high risk of onset of pancreatitis. That's why, first of all, we should exclude cases with secondary hypertriglyceridemia. In patients with high cardiovascular risk, we start the correction of triglycerides if your patient's serum triglycerides exceeds 2.3 millimole per liter, and first choice drug is statins. So if not effective, we combine statins with fenofibrat, but statins plus fibrates, only fenofibrat was recommended, not other fibrates, only fenofibrat. In this case, we control risk of myopathy, and we do clinical assessment, and also other case, we can, as a choice, we can use statins with a combination with omega-3 polyunsaturated fatty acids. About PCSK9 inhibitors, the results of clinical studies, they have estimated and compared annual cost of therapy, and annual cost of therapy with statins was about $186 per year. Unlike them, PCSK9 inhibitors approximately $10,000. That's why we cannot use routinely PCSK9 inhibitors due to economical reason. That's why we try to use combination of other medications. For instance, we can combine statins with other medications, with ezetimibe, for instance. and indications for combined therapy. First, insufficient effect of monotherapy, in order to minimize side effects by using lower doses, and very high level of triglycerides. Possible combinations. These medications these combinations were recommended statin plus ezetimibe. This is safety. This combination is safety and effective statin plus fibrate, but for this case we have to control creatine kinase. Sometimes we can use statin fibrate and ezetimibe, statin plus omega-3 fatty acids plus ezetimibe, sometimes statin plus nicotinic acid, sometimes statin plus bile acid sequestrant, statin bile acid sequestrant, and niacin. These above mentioned first three highlighted combinations, they were recommended. They have more clinical meaning. About intolerance, sometimes when statins are intolerated, we can substitute statins by fibrate plus ezetimibe, or ezetimibe plus bile acid sequestrant, but this combination is not well tolerated due to bile acid sequestrant side effects, and niacin plus fibrate and PCSK9 inhibitors. PCSK9 inhibitor is a good choice for substitution of statins, but one question about cost of treatment. So let's make conclusion. Also, a change in lifestyle is often the method of first choice for lipid lowering. Lipid lowering drugs in general, they can help to control elevated levels of different forms of lipids in patients with dyslipidemia. For medications, we usually use statins in order to decrease level of cholesterol, LDL cholesterol, and we usually use fibrates in order to decrease level of the triglycerides. And statins and fibrates, they have different mechanism of action. Statins, they lower the level of cholesterol. Fibrates, they influence to fatty acids and triglycerides. In addition, other drugs such as ezetimibe, colesevelam, etc., also the other medications also can be used, but for cardiovascular diseases, in order to decrease the risk of cardiovascular complications for patients with cardiovascular diseases, statins and fibrates, they can decrease probability of fatal and non-fatal cardiovascular outcomes in general population. That's why, apart from their lipid lowering activities, these main groups of medications, statins and fibrates, they exhibit multiple functions to modulate intracellular signal pathways, inhibit inflammation, suppress the production of reactive oxygen species, and modulate T cell activity. By the way, number of pleiotropic effects of statins, they are more than 20. And this list of pleiotropic effects, it is not full. The pleiotropic effects of statins, they are under the investigation. In patients with next conclusion, in patients with very high cardiovascular risk, for instance, atherosclerosis, cardiovascular disease, patients with high score, high risk by the score system, patients with familial hypercholesterolemia, chronic kidney disease, diabetes, etc. They have target level of LDL less than 1.4 millimole per liter, and it is main conclusion that management of dyslipidemia is the main reason of management of dyslipidemia. This is decreasing the probability of cardiovascular complication and decreasing cardiovascular risk. This slide is demonstrating a list of references I have used for preparing for current presentation. We have finished the lecture. Thank you very much for attention.